Assalamu alaikum.
Waalaikumsalam, Doktor.
How are you?
Waalaikumsalam, Doctor.
Good evening. So today we have the second session for procedures. Okay, we can start inshallah after Al-Kitab. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين. Okay.
Amin, have you shared the slide? Because I cannot see the screen. Hello, Amin?
I've shared the slide. I reshare again. Hello? Okay. I've shared the slide. I've shared the slide. Everybody else cannot see. My internet connection is a bit slow.
We can see actually.
Go for the second one, for the second slide. So yes. Who will present this one?
I think Faiz is having poor connection. Maybe we can proceed with the next presenter, next topic. Amin, can you proceed with the next topic?
You can, yeah. The Wi-Fi is a bit problematic.
Zira, maybe you can start presenting. Zira, are you there? Maybe you can start present now.
Okay, go ahead.
No, Assalamualaikum. Can you guys hear me?
Yes, yes.
Is it clear? Is it clear? Or the line is quite slow?
Yes, clear.
Okay, so if it is clear, so I will proceed with the presentation first. Okay, so my name is Hazira binti Muhammad Noor. So I'm going to present regarding the electroencephalogram. Okay, next slide. Okay, so this is outline for my today's presentation. First, I'm going to discuss regarding what is EEG, its indication, contraindication, the risk, the type of EEG. Okay, and regarding the procedures, I will touch a little bit revision regarding the anatomy of the brain areas, and also the last I will talk regarding the EEG result. Okay, so what is an electroencephalogram? So actually, EEG is a medical device that used to record the surface electrical activity of the brain and cerebral cortex. Next slide. Next. Hello. Okay. Okay, so proceed with the indication and contraindications in the EEG. So as for the indication, actually this this procedure is used to evaluate several types of brain disorder. For example, epilepsy and also seizures. So as for the seizures and epilepsy, it helps to classify the type of the seizure. It helps to predict the recurrence, and also it helps to in the selection of the anti-epileptic drug. Okay, second, it also can help in the brain lesion disorders. Okay, for example, in the brain tumor, head injury, stroke, and also encephalitis. So in all these brain lesion diseases, okay, usually, okay, the EEG result, it will appear slow. So it depends on the size and locations of the lesion itself. Okay, and then lastly, it also help, okay, to diagnose sleep disorders and also dementia. As for the contraindication, okay, so this procedure, it cannot be performed for those who have the raised intracranial pressure, retinal detachment, pheochromocytoma, and also anesthetic risk. So why anesthetic risk? Because in this kind of patient, okay, maybe they not able to cooperate, okay, in this procedure, and also because of the effect of the medication itself. So it might affect the results of the EEG. Next slide. Okay, so we proceed with the risk of the EEG. Okay, actually, EEG is considered as a safe procedure and it doesn't cause discomfort to the patient. Okay, however, in rare cases, it can cause seizure in a person with a seizure disorder due to the triggering factors. For example, in the case of the hypoglycemia or exposure to the bright light or flashing light, so it can trigger the seizure itself. Okay, other risks that might affect the EEGs, that body or eye movement during the test. Okay, the certain medications such as sedative, or if the patient have the oily hair or with the presence of the hairspray.
What do you mean by risk of EEG?
The risk of EEG itself, so I mean is that when we perform the EEG, okay, sometimes it can cause a problem, just like a problem such as seizure itself. Okay.
So it is not risk of EEG.
The patient.
Important thing to be avoided during EEG. Okay. You mean that? You mean
okay.
that? So I
That's
think,
right, doctor.
yeah, I mean, it may be someone with the risk of EEG. It may be I need different meaning. So to be avoided during, unless recommended something, there is especially flashing light, we can do it as a test after that. A hypoglycemia, it can cause effect and give us like that.
Yes.
So to be avoided during EEG unless indicated. So the rule is try to avoid it unless indicated. Okay.
Thank you, doctor.
Okay.
Okay. Proceed. Next slide. Hello. Hello. Next slide.
Yeah.
Next slide. Okay.
Already,
okay.
the next slide.
Okay, sorry, baru dapat next slide. Okay. Also, basically, there are 3 types of EEG that we need to know. Okay, the first one is routine EEG. So in routine EEG, usually the procedure duration is within 20 to 40 minutes. Okay, and we put 20 electrodes on the scalp by using a special piece, and then we ask the patient to rest quietly and to breathe in and out deeply for a few minutes. Then we record the signals. The second one is sleep deprived EEG. Okay, as for the name sleep, okay, so usually we perform this procedure while the patient is asleep. Okay, and we perform this procedure also when the routine EEG result is not inadequate. Okay, it's inadequate. Okay, so in the sleep deprived EEG, okay, it also helps to record the heart rate, airflow, respiration, oxygen saturation, and also limb movement. And the last one is ambulatory EEG. So it helps to record the brain activity throughout the day and also the night. So there is a small portable EEG recorder that usually the patient will clip on their clothes. So in this procedure, the patient might able to continue their daily activities as usual. Okay, next slide. Sorry, next slide. Sorry, doctor, our Wi-Fi is a little bit problem.
Okay, we expected that. Don't worry. It is time of celebration now.
Okay. Okay. Next. Quiet a little bit late. Oh my God. Okay, next. Okay, next regarding the components in EEG machines. So just this is good for you to know. Okay, before component in EEG machine. The slide before. A component EEG machine. Not the types of EEG electrode. The slide before. Okay, so for the component in EEG machine, it is good for you to know. For example, in EEG machine, we have electrode and then amplifiers, filters, and also the writing unit. Okay, next. Okay, next. Oh, tak ada. The next slide, tak nampak. Sorry, I cannot see this. Okay, okay. So actually there are a few types of EEG electrodes that we need to know. Okay, the most common one that we use in the hospital is these electrodes. Okay, this can be ear clip electrode, just like in the picture, and also intracortical electrodes. Okay, next. Okay, next slide. Sorry, it's quite loading. I'm not sure. Is it okay, doctor, for us to continue our presentations in this condition?
Continue. I can hear you. You don't have one copy of it. You said this is the third. This is the fourth.
Okay, proceed with the electrode. Okay, proceed with the electrode placement. So basically, there are two ways of the electrode placements. Okay, the first one, we can place the electrode separately on the scalp. And the second one, okay, we can place it as a special band on the head. Okay, as just like in the pictures. Next slide. Oh my God. Next. Dah next ke korang?
Procedure.
Okay, for the procedures, okay. So as for the procedures, before you perform this procedure, so the patient need to wash their hair the night before, okay. And the second one, you need to remember to avoid anything with the caffeine on the day of the test, because the caffeine itself, it can interfere with the result interpretation later on. Okay, and then the third one, okay, if for example, the patient perform the sleep deprived EEG, so the doctor may ask you to sleep, to less sleep, or even to avoid the sleep, okay, the night before. Okay, and during the procedures, okay, we ask the patients to lie down on their back in a reclining chair or on a bed. And then the first thing we need to do is that we need to measure the head. Okay, and then we mark we mark spots, okay, where the electrodes will be placed. And these spots then will be scrubbed with a special cream. Okay, and in another part is that the technician will put a sticky gel on the 16 to 25 electrodes, and this electrode later on it will be attached to the various spots in your scalp. Okay, proceed next. Okay, next. Okay, so for the electrode placement, okay, actually we will follow the 10-20 EEG system. So this system, it is based on the relationship between the locations of an electrode and the underlying area of the cerebral cortex. So what it means by underlying area of the cerebral cortex, I will explain later on. Okay, but before that, we need to know that in this system, there are 4 skull landmarks that we need to know. Okay, the first one is nation. So you can refer to the pictures where the nation is. So it is the point between the forehead and the nose. The second is Indian. So Indian at the bump at back of the skull. And then another part is left preauricular point and also right preauricular point. And just like in the pictures, you can see there's 20% and 10% level, right, value, right? So this 10% and 20% value, it refers to the distance between each of the electrode. Okay, you proceed. Next.
العيال النت واقع عندهم. لا بطيء.
Next. Hello. Can we proceed?
Okay.
Okay. Sorry for the problem. Okay. So
Sorry,
sorry.
Doctor, I would like to change my
Uh,
Wi-Fi connection to data because the Wi-Fi is extremely terrible.
Okay.
Can you give me about 1 minute?
Okay.
Okay, thank you,
1.5,
Doctor.
no issue. If you need to send it to me also, it can work with me, maybe better, as you wish.
Okay, I'll try using my data first. Thank you,
Okay.
Doctor. Aku masuk video. Hello, can you hear me?
Yes.
Okay, thank you. Alright. I'll change first. Okay, alright. Can you see the slide?
Yes.
Okay,
Yes.
thank you. Hazira, you may proceed.
Hello. Okay, I'll proceed. Okay. Okay. So we know that our cerebral cortex, we have a different lobe. Okay. For example, we have frontal lobe, we have central lobe, temporal, parietal, and also occipital, right? So actually, okay. Actually, we will place this electrode based on different lobes in the cerebral cortex. Okay. For example, as you can see in the picture, okay, the orange color one, okay, the orange color we will place in the frontal area, okay, and for the red one we place the electrode in the central lobe, and the yellow one we place in the temporal lobe, the blue one we place in the parietal, and the green in occipital. Okay, so and for each of the circle, as you can see, each of the circle, it consists of one letter and also one number. Okay, for example, F7, F3. So it have one letter and one number. So this one letter, it represents the lobe itself. Okay, F for the frontal, C for the central. Okay, and for the number, it represents the right of the side of the hemispheres. Okay, for the odd numbers such as 1, 3, 5, and 7, it represents the left hemisphere. And for the even number, 2, 4, 6, and 8, it represents the right hemisphere. Okay, and electrodes over the midline, it labeled with the letter of Z. Okay, for example, FZ, CZ, PZ, just like what you can see in the pictures. Okay, next. Okay, this is just what we call just a recall regarding the anatomy that regarding the function that we have learned in the year 2, right? So I think this you can read for your own later. You proceed next. Okay, lastly, I will explain regarding the EEG results. Okay, so the result of the EEG, usually it will be based on the waveform that will be produced later on. So what I mean with waveform, so we need to know, it's not 5, sorry, it is 4 major type of EEG waveform. The first one is delta, second is theta, third is alpha, and fourth is beta. Okay, and all of these waveform we can classify according to their frequency, amplitude, shape, and as well as the site on the scalp. Okay, for example, for the delta waveform, okay, it will be produced when patient is sleeping, okay, or having a coma, okay, or having a brain injury. That's a delta wave. Okay, theta, it is related with the emotional stress, too much depression. Okay, and alpha, it is will produce when the patient is stressed, okay, or close their eyes too much, or too relaxed, or daydreaming. And the beta, okay, it will produce when the patient have intense mental activity or too much anxiety. Okay, next. Okay, so this is example of the waveform in the normal EEG and also in the seizure or epileptic EEG. As you can see in the epileptic seizure EEG, you can see there is multiple spikes of waveform as compared to the normal EEG. Okay, next. Okay, this is my references. Sorry for the typo. That's all from me. Is there any questions? No questions. So I think if no questions, we can proceed to the next presenter.
The last slide is not so clear, Hazira.
Okay. Regarding the
No, the next one. Yeah, this one.
Yeah.
So how can we identify now the fits or convulsion here?
I think due to the multiple spikes, as you can see, there's a spike like in the epileptic seizure EEG, you can see there's a multiple spike.
Okay, so how can we say, is it focal, it is generalized?
Oh, sorry, doctor, that's why I'm not sure that.
No, yeah, I mean, because there is there is about 7 or 8 forms of EEG easy to be picked.
Oh, okay.
Like that of absent seizure, which is 3 per second spike, okay? For hips arrhythmia, it is schwatic, all like that, okay? So there is about few forms. If you add it to the slide, it will be more informative. Okay, and we must define when we are going to consider this epileptic or normal, because sometimes the normal may be acceptable from 0 until 25. It may be for elder children, we can accept to 50 like that. But if it is more, so we must able to define, because not easy to set, okay? So our job, if there is a most common one, you just write this one for bitinal epilepsy, this one for Rolandic epilepsy, this one, you just put it, it may be help the others, okay?
Okay, doctor, thank you.
Of course, EEG is out of your scope, but it is a good chance now, instead of wasting our time. Okay, we are trying to get to know what is epilepsy. Of course, you must be able to read what is epilepsy, what is the definition of it, and what can be the causes, and what is the international classification of epilepsy, because all this can come to you in the theoretical exam, and sometimes you need to handle it even for a simple clinical case like patient with complex febrile seizure. So you must able to speak some points even clinically about the EEG. Okay?
Okay, thank you, doctor.
Okay, just complete that one, please. Okay, next.
Okay, can you hear my voice?
Yes.
Yes.
I am Muhammad Faiz Muhammad No. I'm sharing device with the owner of this laptop. Okay. Okay, so my topic will be chest. My topic will be chest physiotherapy and suction. So next slide.
That one.
Okay. So first we chest physiotherapy. Okay, what is chest physiotherapy? It is an mechanical maneuver that we utilize to remove secretion from the chest. So you can read the long definition yourself, but in essence, it means a set of maneuvers that we use to remove the whatever secretion that the chest is holding, and especially in patient who is unable to cough naturally. So this method with chest physiotherapy will be helpful. So is an adjuvant treatment supportive for pediatric patients, especially because sometimes they are not able yet to cough like adults with respiratory and neuromuscular illness. Like for example, cystic fibrosis, asthma, pneumonia, cerebral palsy, and any neuromuscular problems. It's helpful for patients with large amount of secretions or ineffective cough. So these are parts of the lung. So chest physiotherapy will depend a lot on the anatomical position, because we'll see later in the procedure, in the procedure step by step part. We will know later. We need to tap specific part of the lungs that is harboring the secretions. So what is the benefits of physiotherapy? It can help evacuate exudates and secretions. It can also remove obstructions, improve gas exchange, and diminish and reduce breathing effort in a patient with in a patient with rapid breathing because of obstruction. So what is the indication? Like I mentioned, it is used in patient with any respiratory problem or any neuromuscular problem that is inhibiting normal cough or reducing capacity of cough. Like for example, cystic fibrosis, bronchiectasis, atelectasis, whatever disease causing too much secretions or inhibiting cough. So contraindication. Chest physiotherapy is contraindicated in patient with undrained pneumothorax, in patient with hemoptysis or active pulmonary hemorrhage, or in a patient with unstable chest wall, such as fractures, and as well as patients with increased intracranial pressure. So we have three types of chest physiotherapy. We have conventional chest physiotherapy. We will focus more on the first one, which is conventional chest physiotherapy. But we also have modern chest physiotherapy and instrumental chest physiotherapy. So what is conventional chest physiotherapy? It is a set of maneuver that we use, like I mentioned previously, to assist the removal of secretions. We use vibration, we use percussions, squeezing. Basically, we use our hands on the patient to help the patient remove the secretion. So that's why it's important for us to know which part of the lung is particularly affected, so that we can target the specific part to remove the secretion. So it's a manual handling involving vibration, squeezing, and percussion. So this is previously I've mentioned conventional chest therapy, and this is modern chest therapy. If conventional therapy use mechanical maneuver like percussion, squeezing, modern chest therapy involve more about controlling the respiratory flow. But I think in children it's be very difficult because it depends on the patient to do the process by himself, like forced expiration, active breathing. This requires a lot. This requires a lot of effort on the patient's part. And then the third one is instrumental chest physiotherapy. Under the third category, we use instruments such as positive airway pressure, flutter, and incentive spirometer. We use we use it as an adjunct and to provide respiratory support. Okay, so like I mentioned, I will focus more on the conventional chest therapy. So conventional is the most common. The most common procedure used is chest percussion. So how the chest percussion is done? the patient will be put into different position depending on which part of the lung that we are targeting. So we will percuss the specific part, and then the secretion will be removed upon percussion. I will mention how later. So there's also other methods such as control pattern of breathing. This is under the second category, and positive expiratory pressure, which is under third category. Okay, so for conventional, a few principles and rules before we proceed with the procedure. First, it is best done before meals or at least 30 minutes after meals, because we want to reduce the risk of vomiting. And the recommended time to do the chest physiotherapy is in the early morning and bedtimes. So make sure to wash hands and explain the procedure to the patient and the rationale to the patient. And these are the parameters that we can use to assess the effectiveness of the treatment, whether or not patient is improving in terms of respiratory rate, signs of severe breathlessness, arterial oxygen saturation, and length of hospital stay. Okay, first is posterior drainage. So in posterior drainage, we position the patient depending on there is an image later. So we position the patient depending on which part of the lung that we want to tap, we want to percuss. And the procedure must be based on clinical finding. Like I mentioned, we need to clearly know which part of the lung by ausculting the lung. So based on our auscultation findings, we will specifically target that part. And posterior drainage involves assistance of gravity to help remove the secretions. So these are the images that I've mentioned. You can see if you are targeting the upper segment, so you need to position the patient like this. If you are targeting the middle, then you can position the patient like this. It depends. The position depends on which part of the lung that you want to remove the secretions from. So prepare the things which are needed. Prepare the pillows, tape table, the sputum cup for patient to remove the secretions, and paper tissues to clean any mess that may occur after removal of the secretion. And then make sure the patient is comfortable before the procedure starts. And bronchodilators can be used to help reduce bronchospasm and decrease the thickness of the sputum. So this is, like I mentioned, we position the patient depending on which part of the lung that we are interested. So the position as assumed determined by the location, severity, and duration of the mucus obstruction as stated. And then each position we will do the posterior drainage for 3 to 15 minutes. Encourage the patient to deep breath and cough after the 3 or 15 minutes. Okay. Second, percussion. Percussion is also under conventional chest physiotherapy. For percussion, we either use our cup hands or we use percussor cups, like the image that you can see here. So either we use cup hands or either we use percussor cups. We percuss on the part of the lung that we want to remove the secretions from. So use single hand or both cup hands or 3 fingers with the middle finger tented. So make sure the hand is shaped like this, the cup shape. Or we use face mask with the pot either covered or included by the finger, like this, like the picture of the face mask here. Okay, like I mentioned, we position the patient depending on the area of the lung. So if from the bilateral apical segment, position the patient on the nurse lap, on laps, slightly forward. If for anterior segment, make sure the patient lies supine with the back supported with pillow, And for bilateral medial and anterior segment, position the patient on the nurse laps and lean against the nurse. So this is the position of the patient depending on which part of the lung that we want to remove the secretions from. So percuss, place folded towel across the patient's chest to be percussed, because in percussion it involves striking the chest wall, so we want to reduce discomfort for patient. Percuss back and forth in a circular motion, not continuously over one spot. And then we avoid any area of surgical incision. Avoid as well specific parts like spine, kidneys, rib cage, base of the rib cage, and bony prominence. Use with caution in area like breast. And then amount of time is about 30 to 45 seconds per segment, depending on the amount of secretions. And percussion may stimulate patient to cough. Maintain position for the amount of time required to clear lungs, or as limited by patient's tolerance. So after we have done the procedure after we have percussed all the required parts, then we assess back the patient. We auscultate the area. We listen if there is any findings there, or if it's improving or not. Also, we check patient's pulse, respiratory rate, SpO2, and then we properly document the what procedure we do and the results. So vibration is also under conventional therapy. So like usual, position the patient, and then orientate the therapist's hands parallel to the patient's rib anteriorly and posteriorly over the area of the lung. Keep wrists and elbows at right angle. And then like usual also avoid clapping over spine, scapula, clavicle, and breast. So we compress the chest because it is mechanical, so we utilize the vibratory impulse that comes from the hand of the therapy to help remove the secretion. So feel the normal movement of the chest as patient breathe, and then instruct patient to inhale slowly and deeply. As patient inhale slowly and deeply, we vibrate the chest. As patient exhale, instruct the patient to inhale, and then as the patient exhale, we vibrate the chest using the vibration method. Compress the chest while vibrating the chest wall with the hands and moving in isotonic movement that I have mentioned, with elbows at right angle from lateral to medial. And then tense the muscle of the hands and while applying the pressure. Relieve pressure on the thorax as patient inhales. So this procedure is specifically done while the patient exhale. As the patient is inhaling air, relieve the pressure for a while. And encourage the patient to cough using abdominal muscle after 3 or 4 vibrations. So like usual, we do assessment, check patient's pulse and respiratory rate, and also document the therapy that we do. Oh, okay. This is video. I think you can watch the video later. Okay, coughing. So this is the method to help patient to cough. In small children, we stimulate the trachea by placing an index finger just above the sternum notch, and then we give a gentle but firm pressure in a circular pattern. This is to help stimulate cough. And then huffing. Huffing is fast expiration at high volume by the patient. This is more and then thoracic squeeze. Thoracic squeeze. Normal cough mechanism is stimulated by elevating the intrathoracic pressure. This technique does not require any special equipment and is for the thorax. So how we do it, we place the hands at the lower third of the thorax, and then we apply the pressure to increase the forced expiratory volume by 30%. It's not necessary to disconnect patient from ventilation machine during the treatment. Okay, next would be so this is for chest physiotherapy, and then the second part is suction, because the big topic is chest physiotherapy and suction. So I've done for chest physiotherapy. So suction, why suction is very simple, like what we have done in the like as not something different at all from what we have learned during the neonatal resuscitation. So suction is we want to remove secretion by placing an artificial airway. So the benefit, we can help restore airway patency by separating the tongue from posterior pharyngeal wall and maintain adequate oxygenation and provide access for removal of secretion. So indication, evidence of secretion in the airway, but patient have absent cough reflex or an impaired and neurological impairment and fail to clear via either ways, like physiotherapy. If physiotherapy fails, then we need to use suction. So what are the evidence of secretion? If there is any audible upper airway transmitted sounds, if any muffling of the voice, transmitted sound on auscultation, tactile parameters, positive finding of tactile parameters, and moist rattling cough. So contraindication, so we have oropharynx, we have nasopharynx. For oropharynx, the contraindication is conscious or semi-conscious patient, because the patient might gag and vomit. And then for nasopharynx, the contraindication is any nasal airway occlusion, nasal fracture, risk of epistaxis, cerebrospinal fluid leak, basilar skull fracture, and adenoidal hypertrophy. So this is the procedure to do suction. We use wear the appropriate attire like gloves, gowns, and goggles. Position the patient with the head supported in neutral position. Give the patient high oxygen, 100% oxygen for 30 seconds before we do suction. And then prepare equipments and insert the either nasopharyngeal airway or oropharyngeal airway, depends which one you use. So first is how to proceed next with oropharyngeal airway. So the airway can be placed with the with a tongue blade holding the tongue on the floor of the mouth. You can see from the picture here. We depress the tongue and slide the airway with the concave side downward, following the curvature of the tongue. And then do not make sure there is no excessive pressure being exerted on the palate. And there is no need to use any instrument for this method. And make sure we monitor for sign of airway obstruction, sign and symptom of airway obstruction, such as agitation, desaturation, impaired air exchange, and diminished chest rise. And then monitor patient's progress using pulse oximetry, heart rate, and blood pressure. And then for nasopharynx, the tube is lubricated and inserted into the nostrils. Advance the tube gently, following the curvature of the nasal passage. And then use the largest diameter of the tube that can fit the nose. And if passage does not occur easily, attempt to use the other nostril, because different patients can have different size of nasal passage. And then suction the airway frequently to ensure patency of the airway, artificial airway. Then like usual, also monitor the patient's progress using pulse oximetry, heart rate, and blood pressure. So we assess, we look at the skin color and the respiratory rate. We auscultate back the lungs to check whether the signs are improving, and then feel for any improvement in the chest wall. We see the chest is moving properly or not, and also
You have 2 minutes to finish.
Okay.
You have 2 minutes to finish. You are very lengthy. Okay.
Okay, so this is suction. After we have inserted the airway, we do suction. I think you can read this yourself because it's just suction. And then assess the outcomes using all the method of assessment that I mentioned. I think we all know the sign and symptom of respiratory symptoms improvement. And then these are the potential complications of suction, which can be trauma, bleeding, vomiting, transient bradycardia, and laryngospasm. Okay, that's all for the chest physiotherapy and for suction.
Yes, just to come back to the previous slide, please. Thank you. You are Faiz. Are you Faiz?
Yes, Faiz.
Oh, Faiz. Why the patient can go brady?
Because
anyone can answer? This is an important point during suction. If you touch the posterior pharynx, the child can get bradycardia. That's why even if you are doing elective intubation, some are giving atropine to prevent this bradycardia effect. Okay, so it is very important while you are doing a suction, try to avoid touching the posterior pharynx. Okay, which is very important. Another important point, during suction, you must know the suction pressure for every age. As we speak before, during our, for neonate, the pressure from 60 to preterm to 100 for full term, and between this and 400 of the adult, you have range for children. If you are using strong suction, it can also affect, make trauma, make bleeding, make pneumothorax, make bradycardia. So take care about all this, please. Okay.
Okay, thank you, Doctor.
Okay, do you need to ask any question? How many presentation still remaining?
3.
Okay, 10 minutes, please, for everyone. We need to pray in Maghrib.
Okay, so let's proceed with the electrocardiography. So basically, ECG is a test. Next. ECG is a test that, so this is my table of contents. Okay, next. So it is a test to measure the electrical activity of the heartbeat of the patient. So it will provide info regarding the rate of the heart rate, the rhythm, whether it's sinus or not, the depolarization, the repolarization of the cardiac cells, the size of the heart, as well as the wall thickness of the chambers. So bear in mind that some abnormal features in the adults are considered normal in child's ECG, and usually the features in ECG varies with age. Okay, next. So this is indication for ECG. So it is indicated in a patients with known cardiac history or familial history of sudden cardiac death, or patient with cyanosis or loss of consciousness or seizure, or patient have ingested drugs or poisons, and patients are presented with dysrhythmia, or patient who presented with chest pain upon exertion. So they are indicated to do ECG because there might be some pathology of the heart. Okay, but ECG is, there is no specific contraindication for ECG except for if patient refuse to do the ECG. And relative contraindications might be allergies or sensitivity to the adhesive, in which we might give hypoallergenic alternatives. Okay,
I think
next.
you need to change the title of this slide. It is not contraindication to EG. You said if you write contraindication, you write there is no medical contraindication, but we must consider consent of the patient.
Okay.
And we cannot say patient refusal is absolute. I mean, if the patient refusal, we must analysis why he is not need to do it. It may be he is afraid. We will tell him what about the EEG, and it has no harm. Sometimes it may be costly. Sometimes it is like that. But I can't. If the patient tell me, sorry, I don't need to do ECG, and I am suspecting like the patient has infarction, I think I cannot set absolute until I go to the highest level, to the specialist and the consultant, and ask everyone, okay? So I think you need to rephrase this slide. There is no medical contraindication, but we will consider patient acceptance, consent, and we try to, يعني normal counseling can lead to that issue, okay?
Okay. Okay, thank you, Doctor.
Okay, welcome.
Okay, so next, so this is the anatomic importance of ECG, where we place the chest lid. So because baby has physiologically in the uterus, they have right ventricular hypertrophy. So we might have to have a V4 right lid as well. And limb electrodes are placed near the shoulders and hips for less muscle artifacts. Okay. So next, so this is just the brief procedure explanation. So we have to first prepare the machine and make sure it is connected properly and the leads are attached properly to the machines, and prepare the patient, in which we assure the patient of the procedure, and have the patient to remove the clothing above the waist and done the cloth gown opening to the front, and patient should lie comfortably and expose the arms and legs. So the chest sensor application is as follow. So V1, we put it at the fourth intercostal space at the right border of the sternum. V2 lead, we put at the fourth intercostal space at the left border of the sternum. V3, we put at the position between V2 and V4, V4 at the mid-clavicular line in the fifth intercostal space. V5 lead is at the anterior axillary line, on the same horizontal level of as V4, and the V6 lead at the mid axillary line at the same horizontal level of V4 and V5. For the limb sensor application, we put as follows. So for the right arm, we put the red lead, yellow lead at the left arm, green lead at the left limb, and the right limb we put black lead. Okay, next. Okay, so for the complications, basically ECG doesn't have specific complications and it is safe, and it doesn't have any risk of electrical shock. I have searched anywhere, but I couldn't find any specific complications of ECG. Okay, so this is just for you to know. So
we may consider some limitation, like we said in obese patient, we may need to consider interpretation of that. Even in patient of MI, maybe there is 30% of the patient looks like normal EEG at the start. I think remove this complication. We said there is no contraindication, and then you can set under limitation, you can write another slide.
Okay, doctor.
If the patient are very obese, if the patient has thyroid problem, even some diagnosis, as I told you, like MI, sometimes there is a part of it. So it cannot diagnose 100% of the cases. Still, we may need to go further or ask the consultant to opine. Okay?
Okay. Okay, so this is just for you to know the neonates ECG. So this is an ECG of 2 days old infant. So you if you see closely the ECG, you might find there's right ventricular hypertrophy and rightward axis, and there is dominant R wave in the leads V1, V2, V3, and there is Q waves in leads 2, 3, AVF, V5, and V6. And the resting heart rate should be faster than the adults, around 90 to 190 beats per minute. and the PR interval and QRS duration is shorter than the adults, and they have T-wave inversion as well as sinus arrhythmia. But these features are all normal in a neonate. Okay, next. During the infancy or early childhood, the axis becomes more is moving towards the left side, and the R wave started to become normal, and the Q wave started to amplitude. The heart rate started to decrease, but however, the T wave and the sinus arrhythmia may still persist. Okay. For next, for the adolescents. Next. Okay, for the adolescent or late childhood age. So the ECG started to become similar to the adults, but however, some features may still persist. For example, T-wave inversions, V1 V3 at the V1 V at the V1 V2 V3 LED. And sinus arrhythmia may also persist, and there is ST elevation but without reciprocal ST depression, and there might be slight notching or slurring at the J point. Okay. Next. Okay, so basically this is just for you to know the types of pediatric dysrhythmia. So the patients might presented with sinus arrhythmia, sinus bradycardia or sinus tachycardia, paroxysmal supraventricular tachycardia, heart block, premature ventricular complex, bundle branch block. Basically these are almost similar to the adults, but with additional dysrhythmia in pediatrics is that they might have myocarditis or cardiomyopathy as well as myocardial infarction due to Kawasaki disease complication. I think that's all from me. So any question?
You concentrate in how to do the ECG, which you are calling it 12 lead ECG. Okay, so we must be able to know where to put it and how to interpret. I think you need also to add at least how we can comment on the ECG. Formal comment.
Oh, okay, doctor.
So you will write how is the rate, how is the rhythm, how is the axis, how you will find about 8 or 9 points you need to comment. For us, for your time now, it is a top important, okay? And then after that, you will collect piece by piece for different diagnoses, okay? So what is the baseline of reporting the ECG? So now I think you have many slide needs to be corrected before you send it to me again, okay?
Okay, doctor.
Okay, do you need to ask any question?
I think there's no question. Can we proceed, doctor?
Okay.
Okay. So next will be my part, hand washing. So, and also PPE level 1 and continue with PPE level 2 and PPE level 3 by Safia. So for the hand washing, I think this is just a recap because we've learned this and we've done through the exam. So just a recap regarding hand washing is actually basically just application of non-antimicrobial soap and water to the surface of the hand. While hand hygiene encompasses a larger understanding of that covers both the hand washing and also hand rubbing with alcohol base. So what's the function or role of hand wash is actually one is to reduce the transmission of the disease. And also we create a more safer working environment for both the patients and also the medical staff. And we reduce the healthcare associated infection or HAI. So if you don't remember anything, at least remember the 5 moments, which is one designed by the World Health Organization, which is the concept is the 5 moments are one is before touching a patient. So before you approach the patient, make sure you have a proper hand wash before you proceed with any clean or aseptic procedure. Or any third is after any body fluid exposure, and fourth after touching the patient, and fifth after touching the patient's surroundings. So in hand washing, usually the area that we tend to miss the one that is labeled in red. So these are the areas that if we wash our hands without a proper method, we tend to miss these areas. Usually it's like under the area of the fingernails and between the interdigitalis. So this is sorry, it's not this is hand washing, but with alcohol rub or hand sanitizer. So the difference is in the first step, where if you're using a hand sanitizer, you need to put a small amount on the palm and dip all fingers with right and left palm to ensure that you can have a good coverage. Then the steps are palm to palm, right palm over left dorsum and left over right dorsum, and palm to palm again, and finger interlace. Then make sure you wash the backs of the fingers with opposing palms with fingers interlocked. And number 6 is rotational of the right thumb, because this is the area that tends to be missed. And also seventh step is the rotational rubbing of your wrists. And after that, make sure you rinse and dry thoroughly. So this is hand washing with soap and water. The techniques are the same, except in the difference is that you use soap, and then you will directly do rub palm to palm instead of having to put it on a small amount. And the other okay, so this is a
Is
video
there
that
any
you
other
can
difference? Is there any other difference?
there is other difference in the next slides I show. Okay, it's fine. So this is trying to comparing between the aquosa and the hand washing. So first comparison is the germs elimination. For alcohol, it's quite a limited germs elimination as compared to hand wash, which can reduce illness, especially in those with weakened immune system. And the length time required to complete the whole hand washing for alcohol base is much shorter as compared to hand wash. And the accessibility is much easier for alcohol swab as compared to hand wash. As example, alcohol swab, you can see a lot of hand sanitizer are selling in small item products. And usually in terms of recommendation, it's recommend that you go for hand washing if you are able, because it's more superior compared to alcohol based. But if you don't have but alcohol hand wash is an alternative if water and soap is not available. So then last one is just explain just about surgical hand wash, which is the, if you go to the operational theater, you will notice the sink design is a bit more deep and wider. It's because to avoid splash, and they'll provide you a brush for you to remove debris between your under fingernails. And it should be performed using a suitable antimicrobial soap or an alcohol-based hand rub, because we are trying to sterile, make the procedure as sterile as it can be. So related issues regarding hand wash is, one is you can have skin, if you excessive hand wash can lead to skin excoriation, which can lead to the bacterial colonization. And also you can have sore hands may also lead to a decreased compliance with hand wash. And also sometimes inadequate alcohol apply can also reduce in a proper method of alcohol hand wash. Then next to PPE level 1. Okay, PPE level 1 is so in general, PPE is actually personal protective equipment that is used to protect against hazard and risks in the healthcare setting. It's functioning most for the healthcare workers and also the medical students. And there are various of type of PPE which consists of 3 type of level, which I will explain the level 1. And this level 1 is we've been practicing since the first day we had a face-to-face session in the clinical, which is basically consists of the face mask, the plastic apron, the face shield, and also the gloves. So we have the two concept of and the function of PPE level 1 is for any no suspected or no infectious agent or anticipated exposure to blood or other body fluid. And we must remember the concept of donning and doffing. And donning basically is wearing it, and doffing is removing it. So for PPE level 1, when you proceed with donning, first you must wear your face mask, then followed by your plastic apron, wear your gloves, and last with your face shield. But however, when you're doffing it, it'll be removing your glove first, followed by plastic apron, face shield, and lastly would be your face mask. And make sure you remove all those equipment in the yellow hazard bin. Okay, these are the equipments that is for PPE level 1. This is the one that we've been using for the past 1 month. So these are the videos that you can watch that's provided by the IUM Suspect. Okay. Okay, that's all for my part. Any question? Doctor, do you have any?
I need to change your one to be hand. Sorry, you are Muhammad. What's your name? Muhammad what?
Muhammad Al Amin.
Al Amin, mashallah. Amin, I think you need to change your one to be hand washing and the BBE.
Oh, hand washing PPE.
BBE
Oh, okay.
personal. Did you anyone before present the BBE?
No.
I think you need to add just the BBE 1, BBE 2, and the BBE 3.
PP1 and PP2 will be presented by Safia.
Oh, today. Okay, very good.
Today. We divided it.
Okay, okay. See, did you speak about the mask or not?
Yes, I will speak about the mask.
Very good, mashallah. So you are ready. Or are you defending Amin? Okay, go ahead.
Okay, Bismillahirrahmanirrahim. So let us proceed with the next one. Personal protective equipment level 2. So next slide. Okay, so PPE level 2 consists of 2, which is contact or droplets, and another one is airborne. So you need to know the key difference in transmission between droplets and airborne. So droplets is when it's spread by coughing and sneezing, where the droplets the droplet is small, which is it's big, which is more than 5 microns. Compared to airborne, it is a tiny particles and possibly produced by talking and are suspended in the air for a longer time and can travel even further. So airborne is usually less than 5 microns. Okay, next slide. Okay, so let us move with PPE level 2 contact. So when to use, it is when we suspect or confirm there is infectious agents spread by direct or indirect contact. So for example, ESBL, which is extended spectrum beta-lactamase, MDRO, which is multi-drug resistance organisms, and also MRSA, which is methicillin resistant Staphylococcus aureus. So usually on the back of the patient who have these types of infection will have a contact precautions label. So we need to wear appropriate PPE level 2. Next slide. So next is PPE level 2 for droplets. So when to use is when we suspected or confirmed infectious agent that is spread by droplets. So for example, respiratory viruses, and other examples includes SARS, influenza, and also pneumonia. Okay, next slide. Okay, so this is the type of PPE used for the contact and droplets, which include surgical mask, goggle or face shield. Number 3, full body gown. Number 4, plastic apron, and also number 5 is gloves. Okay, next slide. So this is a video for how you donning for PPE level 2 contact and droplets. So basically, the first step is by putting a surgical mask. Number 2, full gown. Number 3, wear an apron. Number 4, face shield, and lastly, you wear a glove. Next slide. So this is for doffing. So for doffing, of course, firstly, you need to remove your glove because the glove is the most dirtiest one. So number 2, you remove your apron. Number 3, remove the full gown. Number 4, remove the face shield. And lastly, remove the surgical mask. Okay, next slide. This one is the video. Later on, you can see the video. Okay, so this is just to show you the picture of how PPE level 2 full looks like. Okay, next slide. So PPE level 2 for airborne. Okay, next slide. When to use is when we suspected or confirmed infectious disease of high consequence spreads by direct or indirect contact. For example, like Ebola virus, Lassa virus spread by airborne route. For example, like MERS-CoV, avian influenza, and also it includes a COVID-19 virus. Next slide. So this is just to show you what they mean by high consequence infectious disease. That includes MERS, Middle East Respiratory Syndrome, Ebola virus, Lassa fever, Nipah virus, monkeypox, and also it includes COVID-19. Next slide. Okay, so this is just to add on some information regarding high consequence infectious disease. It is defined by Minnesota HCID Collaborative as a disease that all forms of medical waste are classified as category A infectious substances by the US Department of Transportation, or has potential to cause high mortality among otherwise healthy people, and no root vaccine exists, and some types of direct clinical specimens pose generalized risk of laboratory personnel or risk of secondary airborne spread or unknown mode of transmission. So basically, HCID includes those who infections can cause pandemic. Next slide. So what are the types of PPE used? They include N95 masks. As I said, that airborne is usually the particles is small, so we need a little bit more protection. So we need to use N95 mask. Number 2, head cover. Number 3, boot or shoe covers. Number 4, gloves, and they suggest to wear a double gloves. Number 5, full body gown. Number 6, plastic apron, and lastly, goggle or face shield. Next slide. Okay, so for donning, for level 2 airborne, first of all, of course, we need to wear the mask, N95 mask, the head cover, the shoe cover, and then after you wear the shoe cover, you need to hand rub first before you wear the glove. And then wear the glove, wear the full gown, and then wear apron, and lastly, wear another glove, the last step. Next slide. Okay, for doffing, we need to remember that every time you remove one thing, you need to hand rub. So first you remove the glove and then hand rub, and then remove the apron and then hand rub, and then remove the gown and then you need to hand rub again, and then remove the head cover, hand rub, and then remove the shoe cover, hand rub, and lastly remove the face mask and again hand rub. Next step, next slide. This is the video part 2 because the video is quite lengthy. Okay, so this is the full pictures of how PPE level 2 airborne looks like. Okay, next slide. So for PPE level 3, I cannot find the source from Malaysia. This one I took it from US, if I'm not mistaken. So basically, they call level 3 as enhanced. So the next slide. So it includes what we call a coveralls attire, and includes a surgical cap. Next slide. Okay, so this is the differences between surgical and N95 mask. So when to use surgical mask is when we want to protect ourselves against large droplets, splashes of liquid, but N95 respirator when we need to protect against small particle aerosols and large droplets, only non-oil aerosols. And then face seal fit. This is required when you wear N95 respirator. We call it as face seal fit test. And then for the surgical mask, it doesn't require a user seal check requirement, but in N95 it is required, as I mentioned before. And then for filtration, surgical mask not reliable, but for N95 respirator, at least 95% of airborne particle is being filtered. And then when to use for the surgical mask, when you close contact to patient with suspected infectious disease. By N95, when you have a close contact with a patient with confirmed infectious disease. Next slide. Okay, this is just to add up about the recommendation by OSHA in the United States when you select a PPE. So what are the 3 things that you need to consider every time you want to choose which types of PPE? First is type of anticipated exposure. So what kind of exposure you will be exposed? This is determined by the type of anticipated exposure, such as touch, splashes, or sprays, or large volumes of blood or body fluid that might penetrate the clothing, and by the category of isolation precautions the patient's on. Number 2, the durability and appropriateness of the PPE for the task, whether a gown or apron is more suitable. If a gown is selected, whether it needs to be fluid resistant, fluid proof, or neither. Number 3 is fit. So PPE must fit to the individual user, and the employer should ensure that all PPE are available in sizes appropriate for the workforce that must be protected. For example, like glove must be fit. There are several sizes of glove that is being provided. Okay, so next slide. Oh, I think that's all from me. Is there any question? I think that's the end of our presentation today. Doctor, is there anything that you like?
Do you have the video done by our hospital? So you can share it to your colleagues?
Yes, we have the videos. I've already shared to them in the slides.
Okay. That's good. That's good. It's very important, please, before going there, to know the 3 level. And you must know an important point. Most of the problem came from doffing, not from donning. Okay. That's to say, you said you are going to remove and wash your hand in every step. Okay. And the last step will be removing the
removing the face mask.
Yes, this is a very important. Okay. So you must take care about that, because they found most of the doctors who infected all over the world, usually because of wrong doffing. Admin study said if you are even dealing with a COVID cases, but you are following the SOP and wear your BBI according to the recommendation, there is no increase incidence of COVID for you, or it is very low. So please take care. This is the most important point in our presentation nowadays. Hoping, inshallah, you will not breach that at all. Okay? Because the first one to be harmed are you. Thank you. Good presentation. I need you to do the correction, and I will send you the marks. Okay? You are group, which group are you?
Group 1, Doctor.
Group 1. Okay. Soon you are going to be examined from 1 to 4 or 5 February, March. Your exam will be from 1st to 5th March.
Yes.
Okay, inshallah, hoping you are study hardly, so you can get a good score, inshallah. Okay. Thank you.
Sorry, Doctor, for the Wi-Fi internet issue just now.
No, not at all. Since we started this online, we are suspected. It is overloaded now, net. Okay. Thank you, and see you again, inshallah. Assalamu alaikum wa rahmatullah.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Assalamu alaikum.
Waalaikumsalam.